Welcome to the Center for Surgical Weight Management at Gwinnett Medical Center, Duluth. During this patient information session, you will learn about the causes and effects of obesity along with the 3 advanced surgical options that we offer. You will hear our bariatric surgeon and medical director, Dr. Robert Richard, explain the risks, benefits, and realistic expectations of each procedure. You will learn what your pre-op and post-op meal plan will look like and find out about all the support services that are offered to help you be the most successful on this incredible journey. Lastly, you will hear what your next steps are if you are ready to change your life forever, improve your health, and reclaim your life. Our medical director, Dr. Robert Richard, is a board-certified general surgeon. Dr. Richard attended Cornell University and Albert Einstein College of Medicine. He fulfilled his surgical, laparoscopic, and bariatric training at Harvard University's prestigious Beth Israel Deaconess Medical Center. He has over a decade of experience performing bariatric surgery procedures. Next, he will discuss the clinical considerations and surgical options available in our program for long-term weight management.
So what is the problem? What is obesity? Is it a lifestyle choice? Many of my colleagues believe that, because when I was in med school, there was no class on obesity. There was no information that was taught to physicians about treating this problem. In the defense of the medical community, for years we didn't have a problem or a large problem in the United States with obesity. That's changed. And a lot has changed recently. I'm going to talk to you a little bit about that. So what is obesity? We know this is a disease. You heard that earlier today. You may not have heard it from your primary care doctors. You may not hear it in the media, but it is a disease. It is a disease of excess amounts of fatty tissue, fat storage. We used to believe that fat cells just expanded and contracted, and they just gave us energy when we weren't, when we needed it, when we didn't have food supplies. But we're learning more and more about this disease. With an excess of fat stores, this disease is a very deadly combination. So it's a multifactorial problem. It's a lifelong problem. It's progressive. We know that it progresses, and we know the endpoint. The endpoint is a shortening of your life expectancy. So what causes the obesity? If you believe it's a disease, what is the cause of it? Well, it's a multifactorial disease. A lot of different things play a role in whether or not you're going to become obese. We know it's genetic. We know that if you raise twins apart, even in different places in the world, different environments, they tend to have the same body style. We know that if you've got 2 obese adult parents, you have a 70% chance of becoming obese. We know that if you have 2 thin adult parents, you have about a 9% chance of becoming obese, even if you were raised outside of that family unit. So if you take environmental factors out of it, we know there's a strong genetic predisposition. We know your metabolism plays a role, how well your particular body turns food into energy. And we know that metabolism changes at different times in your life, different ages, and at different weights. You ever been on that diet and you've lost a lot of weight and you're doing really well on that diet and that pre-prescribed liquid diet, and you are seeing that physician managing that diet every week, and suddenly you stopped losing weight, but you swear you weren't cheating. And that physician gave you that look like, well, we know why you're not losing weight, you're cheating. The reality is that you probably weren't. Your body's metabolism changes as you lose weight. Your body decides to hold on to that weight a little bit better. So your metabolism actually slows. So we know that there's a metabolic component of whether or not you're going to express the obesity gene. Of course, your eating habits, your surroundings, psychological factors. And the more we research, the more we understand that there are even some hormonal factors, things that your body makes that plays a role in whether or not you're going to be obese. There's this hormone called ghrelin. When you eat, when you're hungry, if we measure your ghrelin level, it'll be very high. If we give you a meal and you say, boy, I'm really full, we can measure your ghrelin level and it'll be low. So we know there are some hormones in your body that play a major role in giving you that strong appetite. So there are a number of things that we know play a role in whether or not you're going to become obese. And another problem that we're seeing in Western society is a change in what we consider to be a normal diet. We have had a major portion inflation in the United States and in our society. Just look at this picture. This is at the top corner of that, you see a little girl's plate. She got a quad-decker sandwich, big plate of fries. 3,000 calories. What 12-year-old girl needs a meal with 3,000 calories on it? And everyone gets to pick on McDonald's. Coke, Big Mac, and fries. Now, the reality is that no one in the United States today believes that a hamburger, fries, and a drink is an excessively large meal. We think of that as a standard meal. You didn't have bread, you didn't have butter, you didn't have a salad, you didn't have a dessert. But are you getting 1,580 calories in a hamburger, fries, and a drink? That's too many calories at that meal. If you're trying to lose weight, that's too many calories in a day. You imagine doing that 1,500 calories, 1,600 calories 3 times a day. No matter who you are, unless you're really doing a lot of physical activity, your weight's not going to stay stable. You're going to gain weight. So our perception of what a normal meal is has changed. And we're sedentary. Our jobs are different. We're at computers. We're not exercising. We don't actually do a lot of physical labor in our jobs. So we're a sedentary society. We have portion inflation. And we've got a lot of people with the genetic predisposition or the genes that will allow us to become obese. So in the United States, it has caused a problem. We are in the midst of an obesity epidemic. For almost 100 years, if you look back at some of the data that was kept in the United States, the incidence or the number of people in the United States that were obese was less than 10%. It stayed low for years. Back in 1980, it started to change. So around 1985, the CDC had some data on some states here. The dark blue states, if you look at the incidence or the amount of people in those states who were obese, was 10 to 14%, a sudden rise. So they started keeping better track. And see how this changes over the next 10 years. So from 1990 or 1985 to 96 here, most of the eastern part of the United States, the states in the eastern part of the United States, the population between 15 and 19% of the population are obese. Remember, for years, it was less than 10%. Suddenly, we're up to 20% in 1996. So, we did a whole lot of education back in the 90s. Dietary associations were coming out with their guidelines, new food pyramids. We wanted to educate and motivate the population about the proper diet and proper amount of exercise. But it really hasn't made a dent in this epidemic. So if you look at the latest data we have from the CDC is in 2008, you notice there's some dark red states in the southeast, 30% of the population, 30%. It's a pretty good estimate that this number is going to double in the next 20 years. So we have a major problem. Currently, over 65% of the population, or adult population, are overweight. 32% of children are overweight. And I can tell you almost 20% of kids are obese. And what's scary about this number of kids that are obese is that they're going to be morbidly obese adults. 70% of them are going to be morbidly obese adults. Right now, only 2% of the population are morbidly obese, okay? So the reality is that number is going to be really scary. 4.8, sorry. It's a very costly disease. We know that we're spending billions of dollars treating the obesity, and we know that medical cost is going to increase because the number of people who are obese is increasing dramatically, and it still is continuing to rise. So a bit about terms. You got a chance to check your body mass index outside today, and that is a calculated term. As you remember, they took your height and your weight, and it gives us a good estimate of where your particular weight for your height is. And we have a normal body mass index between 18 and 24. Someone who's overweight has a body mass index of between 25 and 30. Obesity is between 30 and 35. And what we're concerned with is a group of patients that we call severe or morbidly obese. When your BMI reaches 35, and if you have medical problems, or if your BMI is greater than 40 without medical problems, it's about 100 pounds over your ideal body weight. And at that stage, the amount of excess fatty tissue that you have is dangerous. When we look at the mortality risk associated with a higher body mass index, so you can see this curve here. Once this curve reaches 40, it becomes an exponential curve, meaning the rise in this curve becomes a much faster, much higher. This is a mortality curve. This is your relative risk of dying. Now, if I put this another way, if you're a male with a BMI of 40 and you're in your mid-30s, you're going to lose about 15 to 20 years of your life based on this disease alone. So obesity does shorten your life expectancy. Well, you don't just have a problem because of the weight. The obesity, the excess fatty tissue, causes medical problems throughout your body. And you're probably getting those treated now. We know that excess fat stores or obesity causes insulin resistance, which causes diabetes, which leads to diabetes. We know that it causes dyslipidemias, hypertension, sleep apnea, non-alcoholic fatty liver disease, which is a fatty infiltration of the liver that can progress to cirrhosis and end-stage liver disease, polycystic ovarian disease, gynecological problems, infertility, osteoarthritis, cancers. An interesting note about cancers is we know that if you are obese, you have a higher incidence of cancer, meaning that you're more likely to get it. If you get it, you're more likely to have difficulty with the treatments for the cancer, and you're less likely to respond to treatments than if you were not obese. So for a number of reasons, cancer deaths are higher in people who are obese than in people who are not. So when you see a picture like this, what we're really saying is that obesity doesn't leave anything in your body alone. It affects almost all of your organ systems. And the reality is that you're probably getting everything treated but the obesity by your primary care physicians. So what can we do? You can diet and you can exercise, and there are rows and rows of books in the library and in the bookstores on different diets. What that usually tells you is that some of them work, but most of them typically aren't very successful. There's some drug treatments and there's surgery. Let's look at diet and exercise for people who are morbidly obese. The National Institutes of Health looked at morbidly obese patients around the United States, people with BMI greater than 40, and they looked at all the diet and exercise programs that were available. The reality is that they considered you a success if you could lose 10% of your body weight and keep that 10% of your body weight off for 2 years. Only 5% could do it. A lot of people could lose weight. A lot of people can lose a lot of weight on different diets. There are a lot of very popular inpatient diets, the OptiFast diet. There are a lot of other diets that are commercial diets. And you can lose weight. The reality is that it's really hard to keep that weight off. Remember that ghrelin hormone I talked to you about earlier? We know that when you lose that 10% of your body weight, if we measure that ghrelin level, it's actually a lot higher than it was before. So your body wants you to regain that weight. It kind of makes it harder for you to keep that weight off. So diet and exercise has a significant failure rate in our patient population. Well, what about drugs? The reality is that there is no magic drug that's on the market right now. Okay? There is Xenical, which is Orlistat, which is a medication that kind of blocks intestinal lipase and can give you a lot of unpleasant symptoms. And it can get you weight loss, and it's approved for long-term use. It can get you some of that 10% weight loss, but it's real hard to stay on that drug long-term. And the reality is that what do you do when you lose the weight with a diet or with a medication? You usually stop the medication. The disease doesn't go away. So it's a little different than high blood pressure. When you've got high blood pressure, your doctor gives you medication for blood pressure, your blood pressure comes back down, you continue the medication because you understand that that medication is controlling your blood pressure. Well, these medications, phentermine, Bontrol, Adipex, all these medications, we use them for what we call spot therapy. We want you to lose a little bit of weight and then we stop the medication. But the disease doesn't work that way. The disease isn't going anywhere. So when you stop the medication, you should expect that weight to come back, and guess what? It does. So what about surgery? First thing you have to understand about surgery is that it does not cure obesity. We don't cure it. It's still there. Why surgery is different is that we're going to give you a tool that you're going to be able to take with you long term to help control the disease. So who are we talking about? Who is the patient that qualifies or that we're looking for weight loss surgery? It's somebody whose risk from their disease outweighs the risk of any surgical treatment. And that's someone with a BMI of at least 35 with medical comorbidities, someone with a body mass index of greater than 40. Healthy enough to undergo a major operation. Most insurance companies are going to want you to have tried to be successful with diet and exercise, and we believe that that's important also. You need to understand that the surgery isn't the end. You need to be a patient that's willing to participate in a multidisciplinary team. Meaning you need to understand that there are some psychological issues that we want to make sure are addressed. You need to understand that there are going to be some nutritional issues, changes that you're going to have to make. What you're doing now has gotten you into trouble, and you need to understand that we're not going to be able to provide you with an operation that allows you to eat the exact same way that you're eating now and still be able to be successful long term. So there's some dietary changes that are needed. So you need to be a participant in a multidisciplinary program. It is not just a 5-minute or half-an-hour operation that's a quick fix to treating this disease. So there are a lot of surgical options out there today. The three on the bottom are operations that most bariatric surgeons today believe are what we consider our standard operations. The adjustable gastric banding, the vertical sleeve gastrectomy, and the gastric bypass. So I'm going to talk to you a little bit about each operation so you can have a better understanding about what we're doing. First procedure I'm going to talk to you about is the lap band. We do this laparoscopically. We make these small incisions, and we're able to pass our instruments into the abdomen to do the procedure. The lap band system, or the Realize system, are devices that we are able to wrap around just the upper part of the stomach. Once we've wrapped this device around the upper part of the stomach, it has a balloon that lines the band, and we're going to leave it empty initially. But that balloon is attached to an access port that we're going to leave under the skin, so you can't see it, but it's on the muscle layer, so I can feel it in the office. And that allows me to adjust the device. So when I place it, the balloon that lines the band is empty. We're able to slowly add saline to the device once a month, once every 2 months. And this allows me to slowly increase the amount of restriction you have when you eat, so that you're going to feel full off of a smaller portion size. And this allows us more individual control of your weight loss. It's an outpatient procedure. Most people go home the same day. You can lose up to 50 to 60% of your excess body weight in that first year, and some patients are able to even lose more than that. It is a device, and it does require adjustments. I can tell you some of my lap band patients that don't show up for the adjustments are band patients that don't do well. You're not going to lose weight if you're not following up with us and having us to adjust this device once a month or so. So it's a very safe operation. It's the safest weight loss procedure when we talk about the initial operation. The weight loss is good, 1 to 2 pounds or 1 to 4 pounds a week. You can eat most foods. Really, exceptions are going to be thick breads, especially when we get you well adjusted. Thick meats are going to be difficult. A problem is liquids. And I say, well, what a problem are, why is liquids a problem? Is because you can drink them. You can drink sweet tea. You can drink liquids that have a lot of calories in it, and that can slow your weight loss. Now, there can be surgical problems. It's safe, but there are potential problems. One is something called a port or tubing. The port or tubing can leak. If that happens, then the device won't hold the saline, so it really is ineffective, and I'd have to replace the port or tubing. That's probably the most common complication. The band can slip out of position on the stomach. It can erode into the stomach, and there can be an obstruction. Those are less common, but are still potential complications that will require us to reoperate to remove the band. Mortality rate or death rate from this operation is about 0.01%, which is the lowest of any weight loss procedure that we have. So the advantages: the lowest mortality rate, safest procedure. That is the major advantage of the lap band. It is adjustable. Everyone will require a different amount of adjustments, so it's an operation that we tailor to the patient. It is potentially reversible, but when I say potentially reversible, if we remove this band, typically you will regain your weight. So I don't like to think of this as a reversible operation, but potentially it can be. The disadvantages: the weight loss is slower than the other operations, and you need to be able to follow up. The regular follow-ups are really critical. So lap bands, I've got 2 on the market. They're both very good devices, and it is a very safe operation. one of the more popular operations for weight loss surgery. Now, the sleeve gastrectomy is a newer procedure. You probably haven't heard much about it. There's not as much information, or you're not seeing as many commercials on the sleeve gastrectomy. And it's an operation that we've been doing for 10 years or so. So it doesn't have as long of a track record. What we're doing with the sleeve gastrectomy is we're changing the shape of your stomach. We're actually removing that large outer portion of the stomach. We're not using any device. And the part of the stomach that we're going to remove is the major producer of that hormone that I talked about, that ghrelin hormone. So the sleeve gastrectomy. The stomach's an interesting organ. When you eat, you really don't feel full until some of the upper parts of that stomach start to stretch. But the food doesn't hit that upper part of your stomach initially. So what tends to happen when you eat is food tends to enter into the lower part of your stomach and kind of rotates around the stomach, and you'll see that in just a second. So this is a laparoscopic operation, just like the lap band. We're able to do this through small incisions. And with your stomach, food passes down your esophagus, and it rotates around in the stomach before the stomach empties. And it's the very upper part of the stomach, near the esophagus, that when that part starts to stretch, we start to feel full. So that actually happens after a significant amount of food. Well, what we're going to do with the sleeve gastrectomy is that we're going to remove most of this part of the stomach, the lateral part of the stomach. So now when you eat, the very upper part of that stomach near the esophagus stretches very early. So you're going to feel full off of just a few bites of food. We're also going to remove that part of the stomach that produced that hormone called ghrelin, so you're not going to have that real strong appetite. The third way this operation works is that once the stomach empties and into the small intestine, you start to feel satisfied. You kind of feel like you don't need to eat anymore. So because there's a much smaller stomach, it empties a lot faster. So for 3 good reasons, this operation gets us pretty good control of your appetite, and you feel pretty full and satisfied off of a much smaller amount of food. So we're going to remodel your stomach. We're going to alter how it sees food. We're going to alter some of the hormones that your body makes, and we're going to get pretty good weight loss. The risk of this operation is that you're going to have one long staple line, and if that staple line leaks, you can get pretty sick. If we make that sleeve too tight, that's called a stricture, and then food typically doesn't go through, and that can be a problem. And the mortality rate with this is about 0.2%. Now, what exactly does that mean? 0.2% is about the same mortality rate that you have if you were having a gallbladder surgery. So if anyone ever had their gallbladder out, that's about the same mortality rate. So the advantages of the sleeve: doesn't require that I do anything to the small intestine. It doesn't require any adjustments. There's no device. And the weight loss is pretty good. Matter of fact, the weight loss with the sleeve gastrectomy is pretty close to a gastric bypass weight loss in how fast it is. And we hope it's going to be durable. But as I mentioned, this operation hasn't been around for as long as the gastric bypass. So as far as we know, it's a very durable operation so far. So sleeve gastrectomy, our second option, very different than the lap band, but a very good option for weight loss. And I can tell you that as more and more insurers are covering the sleeve gastrectomy, it's becoming more of a popular procedure. Then there's the gastric bypass. And this operation gets good and bad. You've heard good and bad things about the bypass. You've probably heard more about this than any of the operations. I can tell you, in the past, it has given us a bad name. It's been that operation that caused everything. When you get a sinus infection, it's that gastric bypass that caused it. If you got hit by a bus, the gastric bypass caused that. It is actually the most popular operation for weight loss surgery. It's the most effective, and we consider it the gold standard. And I can tell you, it has been performed for over 30 years. It has stood the test of time. We're doing this operation laparoscopically now. You can lose up to 85% of your excess body weight in that first year. No device. And I can tell you, we can really maintain your weight loss. You know, a lot of people will say, well, I know somebody who had a gastric bypass and they regained all their weight. The reality is that most people don't regain all their weight. But what you'll have is somebody who has lost, say, 300 pounds with their initial gastric bypass, but they're still 250 pounds. And they may regain 20 or 50. Now they're 300 pounds. So they're a 300-pound person, and you know they've had a gastric bypass. So your perception is that it failed. Well, remember, they started off at 500. You just don't remember that first person. So the reality is that this operation is very durable, and it lasts and has stood the test of time. We used to do this operation open through a midline incision, and almost everyone got a hernia in that incision, so we are doing it laparoscopically now. Now with this operation, we do more. I have to change the shape of your stomach and create a gastric pouch that is really small, about the size of your thumb when I finish creating it. To do that, I separate the stomach into a pouch, and we're going to basically bypass the rest of the stomach by bringing the small bowel up to the gastric pouch and creating an opening. So you're going to eat, and food's going to enter into this tiny new stomach, and then it's going to bypass the old stomach. So it kind of looks like this. So you have a tiny pouch. So imagine eating a half of an egg, half of a scrambled egg, and feeling like you were really stuffed, you're really full. Because again, that very upper part of the stomach near the esophagus is what's going to be what stretches. That's the part of the stomach that kind of sends that feedback to your brain. So you're going to feel full very quickly, and then that food is going to bypass that old stomach and travel downstream. Now, in addition to getting significant weight loss with this operation is metabolically active. What does that mean? That means that it changes how your body sees things, how your body deals with foods. And so things like insulin resistance and diabetes are corrected very quickly. We'll have patients with this operation that go from being a diabetic before surgery to being someone in remission the day of surgery, not because of the weight loss, but because of how we've altered their anatomy with this operation. So it is a metabolically active operation with powerful effects on the comorbidities for obesity. So there are risks with this operation. Just as with the sleeve gastrectomy, where we staple on the small bowel and the stomach, it can leak, and that is what we consider our most dangerous complication. Bleeding is always a potential complication. The opening from the pouch to that small bowel is called an anastomosis. If it's too tight, that's called a stricture, and that can happen. And the mortality rate with this is about 0.5% nationwide. And when you look at in the hands of a center of excellence surgeon, a surgeon who's done a number of these, the mortality rate is about the same as with the sleeve, about 0.2%, which is again about the same as a laparoscopic gallbladder operation in the United States. So the advantages of gastric bypass: rapid weight loss. We know those long-term results. We've been doing this operation for 30 years. You're going to have more weight loss than with the other operations, and there is no device. The other advantage is that it is a metabolically active operation. It is going to fix those comorbidities very rapidly. Many patients are off of their diabetic medications right after I let them out of the hospital. They're off of their medications for blood pressure even before the weight loss. So this operation has a bit more power in treating the comorbidities than the others. And again, the mortality rate with the band is clearly the lowest. And the weight loss is typically not quite as powerful with the band as with the other operations. So these benefits: type 2 diabetes in remission, often right after surgery with the gastric bypass. The lap band does treat diabetes. We do see decrease in your incidence of medication use for diabetes. We do see diabetes into remission, especially for new diabetics, with the weight loss associated with the lap band. So it won't happen right away. And the sleeve is also a powerful tool for treating these with the weight loss. Safety. Everyone's concerned about safety, especially with bariatric surgery. I guess in the past we have not done a good job of doing this operation in centers where we can control the outcomes in the past. Currently, we have things called centers of excellence where we review the results of these operations, where we have other surgeons peer review our procedures, where we do present our data to central databases, and we do have a responsibility to be safe. And the reality is our centers of excellence around the United States are proving that we're a safe operation. Much safer than heart surgery, much safer than vascular surgery such as an aortic aneurysm, where you can see the mortality rate is about 3 to 4%. And yes, we're going to improve or cure your hypertension, your dyslipidemia, your diabetes, your sleep apnea. That's the real reason for operating. Curing more comorbidities is the real reason for what bariatric surgery does. So what are your expectations? Your lifestyle is going to have to change. what you are doing now has gotten you into trouble. What we want to do for you in the future is to get you to a place where you're going to be able to maintain your weight loss. So we're going to help you understand the changes that you're going to need, the dietary changes, the lifestyle changes that are going to be necessary for long-term health and long-term success with weight loss surgery. We want to improve your quality of life. We want you to look better. And we want you to be healthy. So you've seen some of these pictures before, but always with the weight loss surgery talk, I've got to show some before and after pictures. Our triathlete and our insulin-free patient. Well, I hope I wasn't too long, but I really wanted to let you guys understand that weight loss surgery isn't always about the looks. That's secondary. That's the gravy for me. That's the extra that we get. The reality is that we're operating just as a heart surgeon would. Someone's operating on your heart to save your life. Well, we're operating on you for your obesity to save your life. That's how we look at this. This is not a cosmetic procedure. We're doing this because we know that you are shortening your life expectancy with obesity. That's our philosophy. That's why we're here. And we are hopeful that we're going to be able to help some of you in the future.
Nutrition care is a very important part of our program. Our team of dietitians is dedicated to the nutrition, health, and well-being of our patients. They hold certifications in bariatric and weight management and are certified diabetes educators. We recognize that each person coming into our program brings with them unique nutrition needs and lifestyles. Our dietitians work with you individually. We provide nutrition education, guidance, and support throughout your weight loss journey. Our goal is to keep you nutritionally healthy and to give you the tools that will work for your long-term success. Why is your nutrition so important to us? Optimal nutrition health contributes to a safe surgery, helps prevent diet-related complications, and leads to successful and permanent weight loss. From before your surgery to immediately following your surgery to years after your surgery, our dietitians are with you every step of the way. Here's what you can expect. Before your surgery, you will meet with a dietitian for a nutrition assessment. During this session, you will also learn about weight loss expectations, eating behaviors necessary for weight loss success, vitamin and mineral supplements needed for life, and what and how much to eat after your surgery. After surgery, the size of your stomach will be smaller and the amount of food you can eat will be less, about 1/4 cup immediately following your surgery to 3/4 cup per meal about 1 year after surgery. The nutrition quality of what you eat will be very important to ensure you are getting all the nutrients your body needs. 2 to 4 weeks before your surgery, you will be required to consume a full liquid diet. The purpose of this special diet is to help reduce the size of your liver for surgery. We use a meal replacement product for this diet, and it can be purchased through our center for your convenience. You are also required to attend a pre-op class with a dietitian before your surgery. You will be asked to follow special eating behaviors. These behaviors will be key to preventing diet-related complications after surgery and to start building new eating behaviors for your long-term weight management success. Your dietitian will be in touch with you throughout this pre-surgery process. Immediately following your surgery while still in the hospital, a dietitian will meet with you to review nutrition goals for your first week after surgery before your first post-op visit with your surgeon. You will meet with the dietitian several times after surgery. During these visits, the dietitian will be monitoring your nutrition health and work with you to transition your eating. You will begin with a full liquid diet the first 1 to 2 weeks after surgery, followed by a period of soft pureed foods, and gradually transition to a healthy eating plan that includes lean protein, vegetables, fruits, whole grains, and dairy. This transition varies from person to person based on the surgery you choose and the surgeon's recommendations. At 3 months post-surgery, you will meet with your dietitian to design a personalized meal plan that will support your weight loss goals and journey. Monthly post-op nutrition classes are also available to you that will help you to navigate and establish new eating habits. From eating out to grocery shopping to snacking and stress eating, our classes will give you information you need to build sound nutrition habits. Our cooking classes are specifically designed to address healthy eating options after surgery. We work together with a nationally recognized bariatric chef to bring you the most delicious recipes and latest culinary techniques. As you can see, your nutrition health throughout your journey is very important to us. We take your health seriously and know you do too. By participating in our nutrition program and following program recommendations, you can prevent nutrition-related complications associated with weight loss surgeries. including malnutrition due to poor eating choices, vitamin and mineral deficiency that may not develop for 1 to 2 years after your surgery, making lifelong vitamin and mineral supplementation a program requirement. Weight loss failure due to not adhering to nutrition guidelines. Dehydration, at least 64 ounces of fluids daily, is a must. Anemia, dumping syndrome, a side effect after surgery caused by eating high sugary foods. Hair loss, some hair loss is unavoidable but only temporary, and dry skin. Both hair loss and dry skin can be minimized with good nutrition. You can start preparing for your journey ahead by practicing eating behaviors now that are at the core of long-term weight loss and management success. Take small bites. After surgery, we suggest bites about the size of a pencil eraser. Chew food thoroughly, 15 to 20 times, or to the consistency of applesauce. Eat slowly. Put your fork or spoon down between bites. Periodically assess your hunger level while eating. Stop eating right before you feel full. Drink plenty of fluids every day, at least 8 glasses. Protein intake, especially after surgery, is very important for your health. Daily adequate protein helps preserve lean muscle mass while losing weight. Drinking fluids 30 minutes before or after meals, but not during, helps to ensure you are able to eat the amount of food required on your meal plan. Mindful eating has been shown to have a positive impact on weight management. It is eating with awareness, thinking about the when, how, why you eat, what you eat, and when you feel full or not. It puts you back in touch of your eating experiences so that you can be successful with your weight management. Our dietitians are available for any help or support that you may need. We are here for your success and welcome the opportunity to be a part of your journey. As part of the Center for Surgical Weight Management team, we work together with you to shape new eating and lifestyle behaviors that will support the new, healthier you.
Hello, my name is Deborah Prue and I am the manager for this program. So why our program and what do we have to offer? Our quality program is owned and managed by Gwinnett Medical Center. Because of this, we're able to offer you an extensive multidisciplinary approach to help you reach your goals. Our experienced team of professionals includes our bariatric surgeon, program manager, fitness experts, behavioral health specialists, registered dietitians, technologists, highly skilled nurses, and office support staff. Our surgical team is one of the best. Dr. Richard participates in ongoing education and training with our team to ensure that we are up to date on all new procedures and techniques. Dr. Richard works with a trained team of professionals to deliver the highest quality of surgical care to our patients. Nikki is our office coordinator and is responsible for making your appointments, assisting you with insurance questions, and helping to guide you through the program. She is very knowledgeable and compassionate and warmly welcomes all patients into our bariatric family. Amy is our experienced nurse clinician. Because we are an integrated hospital-based program, Amy is able to follow your care throughout the entire surgical process. She will see you in the office, she will help manage your care in the hospital, and will see you again in the office after surgery. She's the person you would call if you have any medical questions during working hours. It's always reassuring to our patients that Amy is going to provide a continuum of care throughout this amazing journey. All surgeries are performed at Gwinnett Medical Center, Duluth. This new facility provides for the latest technology and is equipped to safely accommodate patients of any size. Our state-of-the-art operating rooms provide ample space, extensive laparoscopic equipment, and up-to-date technology to provide for the safest operation possible. All of our patients are provided a private room with comfortable furniture. In addition, if a patient would like to have a support person stay overnight in the hospital, we will be happy to provide sleeping accommodations for him or her as well. We offer 2 support groups each month which meet on the Glancy campus. Each group provides a safe and trusting environment for sharing information, support, education, and just plain fun. Please check our online calendar for dates and times. We offer a fully stocked clothing exchange closet for our patients to share. We encourage all patients to come and shop for free during their weight loss progress and to drop off any clothing that is now too big for them. This helps our patients save so much money on clothing and is just plain fun to come and shop for smaller sizes. We offer life coaching classes to help support your behavioral changes on this great journey. Our classes are facilitated by behavioral health specialists and cover many topics. Some of the previous topics have been coping with food loss, stress management, love the skin you're in, body image, food addiction, freedom from emotional eating, and many more. We continue to develop new classes to help folks make the important lifestyle changes necessary for successful long-term weight management. We also offer our patients exclusive online access to Chef Dave's services. Through our internet site, patients can view culinary tips, recipes, a bariatric-friendly shopping list, recipe conversions, newsletters, cooking webinars, and so much more. We are the only hospital in our immediate area that offers this free culinary support. In summary, we treat all patients as individuals and help to tailor a program that will offer the best opportunity to manage your weight over the long term. Our program continues to stay abreast of new procedures and technology, as well as continues to provide one of the most extensive support programs found anywhere. So, are you ready to dive in and change your life? If so, let us tell you how you can get started.
Hello, this is Nikki, and I'm going to tell you how to get started on this amazing journey. So who is a candidate? As Dr. Richard discussed earlier, all his patients must meet the BMI criteria for insurance to consider coverage for surgery. If you are unsure of what your BMI is, please use our BMI calculator found on the first page of our website. Candidates must show that they have been overweight for at least 2 to 5 years and have had only short-term success with serious non-surgical weight loss attempts. Insurance companies want to know that you have tried non-surgical weight loss options and that surgery was not your only attempt at weight loss. You must be able to show that you do not have any other disease that could be contributing to your weight gain. For example, an underactive thyroid may contribute to weight gain if not treated. As long as your medical physician has checked you for this, usually done through a blood test, and you are on medication for treatment, you would still be considered a candidate. You will be required to attend a nutrition and psychological consultation, show that you are prepared to attend regular follow-up session, and commit to lifestyle changes. You must be a non-smoker and free of all nicotine products for at least 6 weeks prior to surgery and remain that way after. This includes nicotine gum, smokeless cigarettes, chewing tobacco, and the nicotine patch. These products all interfere with healing, and we want to ensure that you have the safest surgery possible. All females in childbearing years must plan to use 2 types of birth control methods after surgery. When you come in for your visit with Dr. Richard, you will owe 2 copays. One is for Dr. Richard and the other is for Gwinnett Medical Center, as we are a hospital-based program. At this visit, we will provide you with a tentative surgery date and a checklist detailing your pre-surgery requirements. You will have a copay for your nutrition and most likely your psychological consultations. There will be a consultation fee for the fit exercise evaluation, which is not covered by insurance. This consultation fee also includes 1 follow-up visit. Once you have completed all of the pre-surgery requirements, our office will submit to your insurance company a pre-authorization request. Once approved, you will be scheduled for your preoperative testing. At your pre-op appointment, any of your remaining deductible and out-of-pocket amount that has not been met will be due. Our office will check your benefits throughout this process and keep you as up-to-date as possible with your benefit information. If you need to finance all or part of your surgical costs, we can discuss your options with you during your first clinic visit, or we can email you some information. Some possible resources are medical surgical financing companies, employer retirement plans such as 401k or 403b, flexible spending accounts, your local credit union, loan from family or friends, or a home equity loan. So are you ready to get started? If so, please click on the Get Started Now to complete the seminar review and provide us with some additional information. You will receive a confirmation phone call from our office and then an email with a link to go online and complete your application. Once your application is complete, we will process it and call you to set up your consultation appointment with Dr. Richard. If you have any questions about our program, please call 678-312-0000 888-888-6200, and one of our associates will be happy to help you. Thank you for visiting our website and watching our online seminar presentation. We look forward to joining you on your journey to a healthier, happier you.